And so now we want to move on to metastatic castration-resistant prostate cancer. There's a lot of great medications here. We're going to be talking about the PIS3. We're going to talk about the PARP inhibitors. We're going to talk about the Pluvicto. So like we have a patient that progressed, let's say on triplet therapy, or maybe they received a doublet therapy, they progressed on chemotherapy. Dr. Malone, what are your thoughts here? I know you kind of think about the patient in front of you and stuff like that, and because we still have Provenge, right? We still have radium, because in the original studies, the patients received docetaxel, no visceral mets. There was a survival benefit of radium. So what are your thoughts about Provenge and radium?
Well, I think getting Provenge in early with the lower PSA gives the most benefit. That's been proven. So I'm a big advocate of that. I think it's reasonably well tolerated. It stops and starts, so it doesn't eliminate any other therapies. So while that's going on, you can start your approval process for the next step. And the PIS3 study's been really wonderful because it allows us to continue the ARPI or add an ARPI, specifically enzalutamide in that study, with real improvement.
Yes.
And so that's been really exciting, and I've seen an uptake of use as a result of that, a direct result of that study.
Yeah, and I think one of the things is, the overall survival,
Right.
PFS, 0.67, 0.69. So this is a standard of care. And when patients say, or the physicians say, how many of those patients are in that space? I think about patients, did they progress on an AR pathway inhibitor? Or did they have an AR pathway inhibitor, maybe high risk, 2-3 years of ADT with ABI, and they haven't received ABI, and they didn't progress on ABI, and they end up with metastatic castration-resistant prostate cancer because their testosterone was less than 50. Yeah. So I think there are more and more of these patients that qualify for the PIS3. And it's just that maybe they're seeing the urologist instead of seeing the oncologist, because you guys see them earlier.
Right.
Go
Agree.
ahead.
And I agree. I mean, we had a couple of patients that we have treated with radium and Xtandi, but you have to find the right patient. Right?
Yes.
I mean, you have to find bone-only metastasis. They should
Right.
not be having any visceral or lymph node metastasis. And also, they need to be asymptomatic or minimally symptomatic. If they are overly symptomatic from their bone metastasis, this data does not qualify for them. And also, we need to educate these patients that you may not see PSA going down. I mean,
Yeah.
PSA
Right.
in many cases even can go up during and after treatment. So it's a lot of education, finding the right patient population for this treatment, but it's a great study to have.
Yeah, and that has to do with the tumor microenvironment, because you raised a great point, because radium is like an alpha particle without anything around it. And so back when we were in the periodic table and memorizing that in high school, you look at radium, you're like, oh, calcium, oh, radium. So it's like all in the same. And so your body's like, okay, put calcium in the bones. So it puts radium on the bones, it just kills the cancer. That's what we kind of follow alk-phos instead of PSA. Anybody else have any other thoughts on radium, or any kind of pearls for the PIS3 study?
I think PIS3 is compelling. I do think from the medical oncology side, we don't see as many patients who have not seen an ARPI, so it can be challenging. In the right situation, certainly it's great with the survival benefit demonstrated. I know that abiraterone was allowed in patients prior to that regimen in PIS3. The problem is that only about 5% of patients actually had abiraterone. So it's hard to find those people, but if they're there, I think it's a great drug.
Yeah, and this is a news that's going to continue to develop. I mean, we got the DOOR study with docetaxel. We have the COMRAD study that was presented with a PARP inhibitor. So radium looks like it's picking up some steam here. So,
I mean, if there's still a role, even if you don't do a doublet, like as Vikas said, like minimally symptomatic,
Sure.
bone-only disease. I mean, as a single agent, even if patient has been on ARPI, doublet, triplet, I mean, we use radium even as a single agent in those patient population.
There's also some retrospective data that suggests that, as far as thinking about sequencing of things with radiopharmaceuticals, patients that get Pluvicto before, as radium naive or as after receiving radium do just as well. So there may be a role for radium before Pluvicto as well in the right circumstance.
I know Ryan kind of talked about this. I wish all drug companies would use this concept. RALU, RA's radium, Lu's lutetium, RALU study.
Yeah.
It's a no-brainer. But that's right. That's how they came up with the title. But going back to with the radium, I think the key here is it's one treatment every 28 days, and you have to do 6 treatments. We have to get a scan at 3 months, Because if they escape and they have visceral mets, we don't want to miss that.
Sure.
You know,
And the bone-targeted therapy.
and the bone-targeted treatment.
Yeah,
The
really has to
PSA
be
that's
in
not
there.
responding. Yeah, of course.
But yeah, so now we want to kind of talk about the PARP inhibitors. We have the Amplitude study that was presented at ASCO. Very strong PFS. It's kind of early. It didn't show a 0.5. PFS was like in the no overall survival here. But now we want to talk about, since that's not a proven that setting is, you know, what do we think about BRCA2 doublet therapy versus monotherapy? We had the BRCA study that Dr. Maha presented, you know, at ASCO GU. And then you also have monotherapy. And then we have the whole HRR battery, right? PALB2, CDK12, RAD51, RAD54. How do you guys use this HRR in your practice, or BRCA1, BRCA2?
So, you know, for resistance setting, this is always a question, right? Whether you do the combo of PARP and ARPI or do monotherapy. I think there's a role for both. If you do have someone who has progressed on enzalutamide, darolutamide, I usually do a monotherapy.
Yes.
If they have progressed on Zytiga, to be honest, because there is some data that Zytiga, switching from Zytiga to enzalutamide might still work.
Yes.
I might use combo in that setting. But if they have already been exposed to, you know, new generation RPIs, I tend to do monotherapy. I have not changed my practice based on Amplitude study. I don't think there's a role unless we prove an overall survival benefit in sensitive setting. But that's our go-to if you have BRCA mutation. Non-BRCA mutation is a discussion. It's a discussion to be had. It's an approved for all HR mutations. So we do have that discussion, but we all know majority of benefit is driven by BRCA mutations. So.
Yeah, great point. And you know, I think some of the approvals are, you know, there's so much nuance. But you know, if you look at the TALOPRO-2 study with enzalutamide, with talazoparib, you got the whole battery of 12 HRR genes. But then when you have, you know, like the PROPEL study, right, BRCA1, BRCA2, and then magnitude BRCA1, BRCA2. But then if you do monotherapy olaparib, you get all 12 again, you know. So, but that's a great point. Any other thoughts on anything on PARP inhibitors from anybody? On what are the things that you consider? I know with talazoparib, you have to think about the anemia, right? Grade 3 anemia, blood transfusions. You know, any other thoughts from your experience? Ryan, what are your thoughts on experience on PARP inhibitors? Because you've probably written more PARP inhibitors than anybody in the state. We have to learn from you on this. What are your experience on this?
Yeah, I think you know, the patients present at that point, they're beat up sometimes. So sometimes their tolerance of going into that drug is going to be poor. They get a lot of nausea, so I proactively will write them on Dancitron. And I also explained to them that stabilizing their PSA is probably more the goal than actually trying to lower it. And I'm hopeful that with testing improving, that we're going to rule out more CHIP mutations, and we'll see actual mutations, and that maybe our selection can be better, and we'll get the right patient on the right therapy.
Yeah, you know, that's a great point. Like all through college, we learned about homologous repair, 2 copies of all genes, and yet you only need 1 out of the 2 to have a BRCA mutation. So if you have a wild type, that covers up the BRCA2. So do they really have a BRCA2? So how come, like, these companies that check, how come they don't tell us if it's a double hit or a single hit? Yeah. That would really help us. No, I think that's why the response rate is so low, because we don't know if it's single or double hit BRCA2.